So let's take that a step further in terms of your decision of treatment, assuming that this NCD is approved and standard risk becomes more ubiquitous in the space overall. How does that change the practice? How does it change your ability to do more endovascular procedures and just the dynamics of what the money flow means in terms of the way the market.
So maybe I think the surgeons should comment first, because, you know, when carotid stenting trials happen in the United States at the Cleveland Clinic, I've been there 21 years. We were doing 500 carotid stents a year. And, you know, I'm a surgeon, but it was never a difficult discussion with a patient. Do you want an incision or do you want a puncture? And so when therapy is reimbursed by skill and it's up to the clinician, if I have someone I think you can do well either way, I think that we'll see a rise in the overall therapy of number of patients treated. I think we'll see a rise in transfemoral. I think we'll see probably a little dip in TCAR, and we'll see a probably big dip in surgical therapy, just because if you can give a patient a choice either way, I mean, I'm a surgeon. If I can have equivalent outcomes and I can have puncture, I'd have that over surgery. And, you know, you have much quicker recovery and the outcomes are equivalent. And so I think it'll come back to the days where, you know, now we're 90% endodorectomy, 10% stenting. It'll go back to the days where it was 90% stenting and 10% endodorectomy in my institution.
Well, that's the way I choose the therapy for my patients. I mean, I'm a surgeon. I can do all three of them, actually, not TCAR with the commercially available device, but off-the-shelf device. And I try to customize it on the patient I've got. If he prefers a traditional surgery, some patients do ask for traditional surgery, even though they ask for it because reading literature, sometimes in our guidelines, in Italian guidelines, stenting is considered as least as efficient as surgery. And in my language, that means better. But it's always, surgery is always the gold standard. So probably patients who read literature stop at that line and say, I want to, otherwise it's who shouldn't have a stent, who shouldn't have surgery, and the great bulk of the patients can choose what they want on the basis of my experience and their preferences. I think that's where the market should go.
Great. Go ahead,
I was
Chris.
just going to say, it's been on this pause, as you talked about, probably for 20 years. Okay, now for investors on the call, you know, the excitement in my mind is I think that pause is going to be lifted. Right. And then the strategies that are effective and have evidence to support their effectiveness are now going to be much more potentially valuable and needed. Not just valuable for the individual companies, but for other bigger companies who may not have that. They've paused their investment for 20 years. And now those that are ready when the decision comes out will be well positioned. And so I think that with the excitement of the newer devices, the trials that are coming out, it's going to be, you want to be well positioned when the decision comes out. And if you're not well positioned, what you could do is be in a 2 or 3 or 4 or 5 year waiting period. As you know very well, as everybody in the room knows, how long it takes to design a trial, right, go through the FDA, run the trial, get the 1 year follow, whatever it is. I think this is an exciting time to have a good technology ready to go.
So